Hello student, now we are going to discuss cardiac output. So all of you know the definition of cardiac output. It is the volume of blood ejected by a single ventricle in 1 minute, right? That is the definition of cardiac output. So in the previous session, we have discussed that the stroke volume of a normal ventricle is 70 to 90 ml, and we have also discussed that end diastolic volume of a single ventricle is 130 ml, right? So by definition, stroke volume was nothing but it is the volume of blood ejected by a single ventricle per stroke in 1 beat, right? So obvious thing is that if I multiply this stroke volume with the heart rate of the person, then I am going to get the cardiac output or the total volume that will be ejected by a single ventricle in 1 minute, right? And the normal value of this cardiac output is 5.4 liter per minute for a 70 kg adult body weight person, right? Sometimes apart from this cardiac output, cardiac index is also calculated. Cardiac index is also calculated, and cardiac index is simple: cardiac output upon body surface area of the person. So cardiac output is 5.4 liter per minute, right? And body surface area is 1.7 meter square. This is the value for a normal adult body weight, 70 kg body weight person. So obviously the cardiac index has an average value of 3.2 liter per minute per square meter of body surface area, right? So you have to remember this cardiac index. Sometimes it can be given as an MCQ, right? Given as an MCQ. Now apart from this, you know, if you take the percentage of stroke volume upon your end diastolic volume, and if you take percentage of this is known as the ejection fraction percentage, right? Ejection fraction percentage, stroke volume upon EDV, and normally the ejection fraction is 65%. That is the normal value of ejection fraction, although it has a normal range, that is 55 to 70% is the normal range of ejection fraction. So these are the some numerical value that you should remember for your MCQ. Now next discussion is how to measure the cardiac output, right? So I want to measure the cardiac output. There are various methods, as you can see over here: Fick's principle, dye dilution, thermodilution, echocardiography, impedance cardiography, as well as MRI. Many methods are written here. So what we have to remember for our MCQ purpose is that first, the number one method, that is the Fick's principle method. Remember, this is the best method for measuring cardiac output when the cardiac output is low, right? Suppose you are assuming that the cardiac output of this person will be lower than normal, then you apply the Fick's principle, you are going to get the best result. So best method for low cardiac output state of the body, low cardiac output states of the body, right? Now second, that is the dye dilution method as well as this thermodilution method. Both of these methods are based on a same principle, and that principle was first time discovered by two scientists, S-T-E-W-A-R-T, Stewart and Hamilton, M-I-L-T-O-N, Stewart and Hamilton principle or Stewart and Hamilton method. So please remember, dye dilution method as well as this thermodilution method, they are based on the same principle which was discovered by Stewart and Hamilton. That's why this is known as Stewart-Hamilton method. Dye dilution is also known as indicator dilution method. Previously it was used, but nowadays this dye dilution has been replaced by newer version method, that is the thermodilution method. So what we have to remember about dye dilution method? Dye dilution method is also known as indicator dilution method. Indicator dilution method, right? So this method is the older version. It has been replaced by the newer version, that is the thermodilution method. For thermodilution method, you have to input one catheter at the level of pulmonary artery. I will tell you the method, just hold on. That's why thermodilution method is also known as pulmonary artery catheter method. And remember, this is the gold standard method for cardiac output measurement. Am I clear? So please remember, there are multiple confusion that which method is the best for cardiac output measurement. But remember, thermodilution method is the gold standard method for cardiac output measurement. As well as you also remember that thermodilution method is the best method. Okay, it will give you the best method when the cardiac output is high. So high cardiac output state of the body. High cardiac output state of the body. If you apply this thermodilution method, you are going to get the best result. Getting my point? So if your question is asking which of the following is the best method for cardiac output measurement, go for thermodilution method. But if it is specifying that a person is having low cardiac output state, in that cases the best method is the fixed principle method, right? So this way you have to remember certain point about this method. Now this number 1, number 2 and number 3, all of these three methods are invasive method, right? I will describe the method, you will understand that all of these three methods are invasive method. But if you look at the method number 4, so obviously all of you know that echocardiography is the non-invasive method, and this is the most common method for measuring cardiac output. Okay, because it is very easy to measure the cardiac output by echocardiography. Simply you have to measure the stroke volume by assessing the velocity of blood through the arch of aorta and multiply that stroke volume with heart rate. You are going to get the cardiac output by echocardiographic principle. But please remember that this is also the least accurate method. So please remember, although this is most common method, but echocardiography is also the least accurate method for cardiac output measurement. Although we use this method more commonly, but it is the least accurate method for cardiac output measurement. Now look at the method number 5, very important, recently given in Guyton. This is known as impedance cardiography or thoracic bioimpedance. So you know the meaning of impedance. Impedance is nothing but kind of total resistance. So what is done in this method of this impedance cardiography? Electrodes are placed on both sides of the neck, as well as electrodes are also placed at the lower part of the chest. Then a low amplitude current is passed through this electrode and other electrode record that current. During this flow of current, we assess the impedance or resistance of the thoracic cavity. Getting my point? So whenever one current is flowing through this thoracic cavity, every organ which are there inside the thoracic cavity, they will produce some resistance. Not only that, the blood which is present in the heart, the blood which is flowing through the arch of aorta, that will also give some resistance, and by calculating this resistance, we calculate the cardiac output of this person. Getting my point? By this method, whenever beat to beat blood flow is changing from the heart, the cardiac output will also change, and this is the method which can measure the cardiac output in beat to beat fashion. Means for every beat, it can measure the cardiac output by measuring the resistance across the thoracic cavity. That's why it is known as thoracic bioimpedance method or impedance cardiography method. This method was first time discovered to measure the cardiac output of astronaut, but nowadays this is also used for research purpose, although there are many variability in this measurement, and in Guyton it is said up to 20% error can occur by this thoracic cardiography method, right? Okay, and the last method is written MRI. There is a special version of MRI, that is velocity encoded phase contrast MRI, right? This is the MRI which is used for measuring cardiac output, and remember, this is the most accurate method for cardiac output measurement, even it is more accurate than this thermodilution method, also more accurate than Fick's principle also. So what I am saying, that if in your option you are getting MRI, then that is the most accurate method. Okay, even if the thermodilution is given in the choices, you have to mark MRI. But because this method is not used clinically, okay, it is only used for research purpose till date. Okay, we are not using this MRI method for clinical medicine. That's why in your MCQ you may not get a choice of MRI. But if you are getting a choice of MRI, then remember that this is the most accurate, okay, method for cardiac output measurement. Getting my point? So these are the 6 various methods that you have to remember, that these are used for cardiac output measurement. Now we have to discuss a little more detail about the first 3 methods, that is the Fick's principle, dilution and thermodilution, because we have seen many MCQs from this region. Okay, so Fick's principle. First, Fick's principle, right? Right. So first method is the Fick's principle. What I told, that Fick's principle is an invasive method, and this is the best method for low cardiac output state. Now let's see how it is done. Right. So this method is based on oxygen consumption measurement at the level of lung. What I am saying, suppose this is your lungs, right? You are measuring that how much oxygen you are consuming from the level of lung in 1 minute, or how much oxygen is absorbed from the lung in 1 minute. Whatever amount of oxygen is absorbed in your lung, that much amount of oxygen will be utilized by the body. So oxygen consumption or absorption from the lung will be steady state, right? So suppose this is lung, it is consuming certain oxygen, and we also know that venous blood is reaching towards the lung and it is oxygenated to form the arterial blood. So this is the venous blood and this is the arterial side, blood is going out. Okay, so this is the venous blood. If you look at the venous blood oxygen content, normally the venous blood oxygen content is 15 ml oxygen is present per deciliter of blood. Per deciliter means 100 ml blood. So 15 ml oxygen is present in 100 ml of venous blood. And if you look at the arterial blood, right, arterial blood, then it contains 20 ml of oxygen per deciliter of arterial blood. So I can find out that the difference between artery and vein, artery minus venous difference here is 5 ml. So where from this 5 ml oxygen is coming? I can easily understand that this 5 ml oxygen is absorbed at the level of lung. This 5 ml oxygen is absorbed at the level of lung. Now, suppose I have already measured that how much amount of oxygen is absorbed from the level of lung in 1 minute, and that is suppose 250 ml of oxygen is absorbed in 1 minute. That I have already measured, right? And then I have calculated that what is the venous blood oxygen content and what is the arterial blood oxygen content, and I can calculate the difference between them. Now I can say like this, that 5 ml oxygen is consuming or absorbing, okay, by 100 ml of blood, 100 ml of blood, right? Because this artery venous oxygen difference, I told you that 15 ml per deciliter, deciliter means 100 ml. So this 100 ml blood is reaching at the level of lung, and that 100 ml blood is taking up this 5 ml of oxygen from the lung, right? So 5 ml oxygen is taken up by 100 ml of blood. So how much oxygen is consumed by lung in 1 minute? We have already calculated. So 250 ml oxygen will be consumed by how much ml of blood? So this is very easy, multiplied by 250. So this will be, okay, 500 ml of blood. This volume of blood which you have just calculated, this is nothing but your cardiac output, right? So how are you measuring cardiac output by this Fick's principle? You are dividing, okay, oxygen consumption, that is 250, upon your artery venous oxygen difference, right? So this way you are measuring the cardiac output by Fick's principle. That's why it is said that according to Fick's principle, cardiac output is equal to oxygen absorption or consumption, oxygen absorption at the level of lung, in 1 minute upon your arterial oxygen content, arterial oxygen minus venous oxygen content difference. Okay, so arterial oxygen content minus venous oxygen content difference. This way you can calculate the cardiac output by Fick's principle, right? So how can you measure the oxygen absorption from the lung in 1 minute? This can be easily done by simple spirometer. So this can be easily done by simple spirometer, right? So you have to attach one spirometer to the person whom you are planning to measure the cardiac output. Then you measure how much oxygen the person is consuming in 1 minute. Normally this is around 250 ml, right? Then you have to also measure the arterial oxygen content. Which arterial sample is taken for this Fick's principle? The best artery from where the sample should be taken is the brachial artery, but the puncture of the brachial artery is little difficult, so that's why radial artery is more commonly used, but the best sample for arterial blood is taken from brachial artery. And if I ask you venous blood sample, from where you can take the best sample of venous blood? Okay, not any peripheral vein, because you know that superior vena cava and inferior vena cava, they are draining their blood at the level of right atrium. Okay, and then when the blood is going from this right atrium towards right ventricle and then pulmonary artery, at the level of pulmonary artery there will be whole mixing of this superior vena cava blood and inferior vena cava blood. That's why it is said that best mixed venous blood sample, best mixed venous blood sample is taken from pulmonary artery level. So please remember, for the Fick's principle you have to introduce one catheter at the level of pulmonary artery, from where you have to take the mixed venous blood sample. Okay, that is the best sample, and you have to puncture the radial artery or brachial artery, from where you have to take the arterial blood. In both the sample you have to measure the oxygen content, and by using the spirometer you have to measure how much oxygen the person is consuming. By this way you can calculate the cardiac output from the person. So obviously this is an invasive method, you can easily understand that, right? So this is all about your Fick's principle. Now coming to the second method, that is known as dye dilution method or indicator dilution method. Dye dilution method. I told you that dye dilution method is an older method based on Stewart Hamilton principle. The name of the dye which is used for this purpose is known as indocyanine grain dye. Indocyanine green dye, right? So this name may be given as an MCQ, so try to remember that the name of the dye is indocyanine green dye. Now what you are going to do in this method, suppose this is the chambers of the heart, right? Okay, so first of all you have to place one catheter at the level of this right atrium chamber. Okay, and you have to inject certain amount of dye at the level of this right atrium only. So where you are injecting the dye, you are injecting the dye directly at the level of right atrium, certain fixed amount of dye, and suppose that is q milligram of dye you are injecting at the level of right atrium, right? Then this dye will be dissolved in the blood, and then it will pass through this pulmonary artery, then it will go to the lung, and from there it will reach in the left atrium, from there left ventricle, and then it will be entering in the systemic circulation. Now when it is going through the systemic circulation, you have to take arterial sample. Okay, best again the brachial artery sampling. So you are taking sampling from this arterial. Okay, arterial sampling you are taking. Okay, blood sample is taken, and in this sample you are measuring the concentration of this dye. Okay, which dye? The indocyanine green dye. That concentration you are measuring. So you have already injected certain amount of dye and you are taking multiple arterial blood sampling. Okay, at a regular interval you are taking continuous blood sampling from artery, that is brachial artery or maybe radial artery, and you are measuring the concentration. So if I plot this, okay, this concentration of the dye along with time, okay, in the arterial blood. So I am plotting this concentration measurement at the level of arterial blood. So x-axis is time, okay, and y-axis is the concentration of the dye in the arterial blood. Suppose this is the 0 point where I have given injection of the dye. So obvious thing is that whenever you are injecting the dye, immediately you are not getting any concentration in the arterial blood, okay, because it will take some time for this dye to pass through this all circulation and then it will reach in the arterial blood. So after few seconds, maybe 1 or 2 seconds, the concentration of the dye will start appearing in the arterial blood and then it will go on rising. So the concentration of the dye in the arterial blood, so see, I am taking multiple concentration and I am measuring that the concentration is continuously rising in this arterial blood sampling, that is the brachial artery sampling, and then after certain point of time this concentration will start decreasing. The concentration will start decreasing. That is very obvious, right? But this dye concentration, if you plot like this, it is not going to touch the baseline immediately. Why? Because some of the dye from this arterial circulation, again it will recirculate back into this right atrium. By the time it will reach to 0. Getting my point? So that's why it will never reach to 0, because some of the dye will recirculate back and it will follow a pattern like this. It will follow a pattern like this. So what you are measuring here, you are measuring the continuous concentration of the dye in the arterial blood sampling over time, right? Over time. So after getting this graph, what you have to do, you have to extrapolate this curve on this x-axis. After this, you have to measure what is the average concentration. So this is known as the time concentration curve. So in this time concentration curve, you have to measure what is the average concentration during this time period. Okay, so what you are measuring? You are measuring the average concentration of the dye, and you also have to measure what is the time duration of this window, right? If you can calculate this average concentration and time duration, then the formula for calculating cardiac output by this indicator dilution or dye dilution method is that amount of dye that is injected, suppose Q milligram, so the unit will be in milligram, upon your time concentration. So time, okay, that you have to take in seconds, multiplied by average concentration of the dye. So average concentration you have to take in milligram per ml unit, right? So by this way, if you put all these parameters, you are going to get the cardiac output of the person. But you look at here, the time is taken in second, but cardiac output is measured in 1 minute. That's why you have to multiply this with 60. So this is the whole formula of Stewart-Hamilton principle. This is the whole formula for dye dilution method by which cardiac output is calculated. You have to remember this formula, that amount of dye injected upon your time concentration. The question will be given, different value will be given. You have to just put the value into this equation, but please keep in mind that what is the unit. If it is given in milligram per ml, that is okay. Otherwise you have to convert the unit into milligram per ml, and here the time you have to convert into second, right? And amount of dye which is injected, that unit also has to be in milligram, right? So this way the dye dilution method is used, right? Okay, so again you can understand that the dye dilution method is again an invasive method, because you have to put one catheter at the level of right atrium and you have to puncture the artery like brachial artery or radial artery, right? Okay, now I told you that this dye dilution method has been replaced by newer version of method that is known as thermodilution method, and which is the gold standard. So thermodilution method, okay, here the principle is same, but rather than injecting dye, we are injecting certain amount of temperature. Certain amount of temperature means certain amount of water, maybe cold or maybe hot, right? Not exactly water, but normal saline. So look at how this thermodilation method is done. Just some principle you have to remember, that how this method is done. The detailed version is not required. So again you have to put one catheter, okay? So but in these cases the catheter tip should be placed at the level of pulmonary artery, right? So this is the tip of the catheter, and the tip of the catheter where it is placed at the level of pulmonary artery. That's why I told you that thermodilution method is also known as pulmonary artery catheter method, because the tip of the catheter is located at the level of pulmonary artery. Why? What this tip is doing? This tip contain a thermistor, THERMISTOR. So this is a probe which can measure the change of temperature. Thermistor tip, right? So the thermistor tip is placed at the level of pulmonary artery, and this catheter also contain one opening at the level of right atrium. Through this opening we are going to inject certain volume of temperature, certain amount of temperature. Certain amount of temperature means normal saline will be injected at room temperature. So what you are doing in thermodilution method, you are giving injection of temperature in the form of 10 ml normal saline, 0.5% NaCl solution, which is injected at room temperature, and this injection should be done at the end of expiration. Why end of expiration? Because you know cardiac output changes during inspiration and expiration. So there is a fixed method. So whenever you are injecting the saline here at the level of right atrium, how much saline you are injecting? 10 ml, and that is 0.9% NaCl is injected, and this is injected at room temperature, means the normal saline which you are injecting at room temperature. Remember, although you are injecting at room temperature, but this is a cold saline with respect to body temperature, because your core body temperature is 37 degrees centigrade, and whenever you are injecting saline at room temperature, that will be equal to cold. So you are injecting certain amount of temperature here in the form of cold water. So what will happen? This will be diluted with the blood, and when this diluted blood, okay, it will change the temperature of this diluted blood, and when this blood is reaching at the level of this thermistor tip, it is going to measure how much change of temperature is occurring here. So by this way, the amount of temperature injected and how much change of temperature is occurring, the cardiac output of the person is calculated by putting all these parameters into a mathematical equation, right? So only thing you have to remember, that where the cold saline is injected and where from the temperature change is measured. That's the two things you have to remember for thermodilution method. But you know that whenever you are applying thermodilution method, although it is a gold standard method, there are some problem in this method. Problem will arise if there is sudden regurgitation of blood from the level of pulmonary artery to the right ventricle. That is the pulmonary regurgitation. So pulmonary regurgitation, or if the blood is regurgitated back at the level of this tricuspid valve, that is the tricuspid regurgitation, or if there is presence of certain intracardiac shunt, like for example in VSD or in case of ASD, this method will give you erroneous results. So that's why you have to remember pulmonary regurgitation, tricuspid regurgitation, VSD, ASD. In these cases you cannot use this thermodilution method, because it will give you the erroneous result. So this is all about the three major methods for measuring cardiac output. So we have started our discussion from here. Okay, now we all know the detail of this sixth method. You don't have to remember detail about this impedance or echocardiography. You just remember whatever I have already told you, right? So this is about cardiac output measurement. Okay, now after measurement of the cardiac output, the more important thing is that you have to remember how the cardiac output is regulated. Okay, so next topic is regulation of cardiac output. Regulation of cardiac output, right? It is very simple. We have already discussed that cardiac output is nothing but stroke volume multiplied by heart rate is equal to our cardiac output. So, any factor which is changing the stroke volume is also going to change cardiac output. So, three factor I have to remember which is going to change the stroke volume. Number one, preload, right? Number two, contractility. And number three, afterload, right? So preload is positively related with stroke volume, means whenever the preload is increased, stroke volume of the ventricle is also going to increase. Contractility is also positively correlated with stroke volume. More the contractility, more will be the stroke volume. But afterload is negatively correlated with stroke volume. More the afterload, lesser will be the stroke volume, right? So we are going to discuss detail about all these three things. But before that, how the heart rate is regulated. We all know that heart rate is under the influence of two systems, that is the sympathetic and parasympathetic system. Dominantly the parasympathetic is going to control, right? Apart from that, we also have to remember two major reflexes, that is the Bain-Briggs reflex, okay, as well as the baroreceptor reflex. So these are the two major reflexes which are also going to control your heart rate, right? So regulation of the heart rate is done by this. So you are going to get the cardiac output if you multiply this stroke volume into heart rate. Now if you multiply cardiac output with total peripheral resistance of the person, then you are going to get blood pressure. Which blood pressure? Mean arterial pressure, MAP, or mean arterial pressure, right? So now we are going to discuss one after another. We are going to start from this preload. So what is the meaning of preload? Very, very important for your MCQ, right? So if I write down preload, okay, preload. So pre and load. Pre means, remember like this, pre means it is before, okay, and load means it is nothing but tension. So before means before onset of contraction, the load on ventricular muscles, before the onset of contraction is known as preload. Is it difficult? Very easy. So pre means before and load means tension, right? So before the onset of contraction, what is the load on ventricular wall? That will be known as the preload. Now I am starting to think that ventricle is not contracting, but still it is getting load. So why it will get the load? So I am thinking of this ventricle, it is not contracting, means the ventricle is in which stage? The ventricle is in stage of diastole, right? So during diastole, the ventricular wall is getting some load or tension, and that load will be due to presence of certain volume of blood into this ventricular cavity. So I can easily understand that because of the volume of blood which is present in the ventricular cavity, the ventricular wall will get some tension, and this tension, although it is less, but this tension will be known as the preload. So my definition is before the onset of contraction. So we have to think of that before the onset of contraction means which stage of diastole we are talking about. If you think of cardiac cycle in our previous discussion, then the diastole is composed of protodiastole, then isovolemic relaxation, then first rapid filling phase, then diastasis, then last rapid filling phase. After the last rapid filling phase, the contraction will start. So I can understand that preload means it is measuring the load at the end of diastole. At the end of diastole means I can understand like this, that at end of diastole mean it is talking about end of last rapid filling phase. So what is the volume of blood present in the ventricle at the end of diastole or at the end of last rapid filling phase? That volume is nothing but your end diastolic volume. That's why it is said that preloads depends on the volume of blood which is present at the end of diastole, and that volume is known as end diastolic volume. That's why it is said that the best index of preload, look at what will be your MCQ. Your MCQ will be like that the best index of preload is equal to, your answer will be end diastolic volume. If it is not given, then end diastolic pressure. So because of the volume there will be some pressure. We know what is the end diastolic pressure for right ventricle, that is 1 to 5 I told you already, and for the left ventricle that is 4 to 12 or 5 to 12 millimeter of mercury, that is the end diastolic pressure. So if end diastolic volume is not given, then you go for end diastolic pressure. So this is nothing but your preload. Now if the preload is more, means end diastolic volume is more, so what will happen to the tension? Tension will be more. So simple thing is that more the end diastolic volume, more will be the tension of the ventricular cavity at the end of diastole. What will happen to the length of the ventricular muscle in this condition? So whenever you are injecting more and more blood in the ventricle, whenever you are giving more and more blood, what will happen to the length of this ventricular muscle? Obvious thing is that ventricle will also go for more and more stretching. So more blood is coming to the ventricle, more stretching of the ventricular muscle. That's why we said that the initial stretching of ventricular muscle, initial stretch on ventricular muscle before the onset of contraction, is also known as preload. Getting my point? So this is the second definition of preload, that it is the initial stretch. Previously you have defined that it is the load on the ventricle before the onset of contraction. Now we are defining the preload as initial stretch on the ventricular muscle before the onset of contraction. So main thing is that preload means it is the diastolic load. At the end of diastole, what is the tension in the ventricular wall, and that is equal to end diastolic volume. Now I am asking myself again that end diastolic volume depends on which parameter? Very simple, that this ventricle is connected with the atrium. Whatever blood is returning at the level of this atrium through the superior vena cava and inferior vena cava, that is known as the venous return. So more the venous return, more will be the blood in the right atrium and more will be the blood in the right ventricle, and similarly for the left atrium and left ventricle also. So basically I can understand that end diastolic volume depends on venous return. That's why it is said that the best determinant of preload, okay, best determinant of preload is venous return. Getting my point? So two questions. If the question is what is the best index of preload, then your answer is end diastolic volume or end diastolic pressure. But if the question is best determinant of preload or end diastolic volume, your answer is venous return. So I can write down here that preload is dependent on venous return. So more the venous return, more will be the preload, more the preload, more will be the stroke volume of the ventricle. Getting my point? Now, whenever we are discussing preload, we told you already that it is the initial stretch of the ventricular muscle before the onset of contraction. You know that whenever your end diastolic volume is increasing gradually, there is increase in length of ventricular muscle. There is increase in length of ventricular muscle, right? Whenever you stretch ventricular muscle more and more, what will happen? This will leads to increase force of contraction of the muscle of ventricle. Getting my point? So what I'm saying, so whenever your end diastolic volume is rising more and more end diastolic volume means there is increase in length of the ventricular muscle more and more. If you stretch ventricular muscle more and more, what will happen? The ventricular muscle will contract more and more forcefully, right? So more stretch, more contraction, more stretch, more forceful contraction. This relationship, okay, is known as Frank-Starling law. This relationship is known as Frank-Starling law of ventricle. Getting my point? So basically, more you stretch the ventricle, more stronger contraction it will give. This is known as Frank-Starling law of heart. Right. So what is the cause of this Frank-Starling law? See, this similar kind of principle we have also discussed in skeletal muscle. In skeletal muscle, we told you a relationship which is known as length tension relationship. Could you recall that? Okay, so more you increase the length of sarcomere, more will be the tension generation. The same thing is also happening here. More you stretch the ventricular muscle is contracting more. So the principle is similar to the skeletal muscle principle. There we are saying the length tension relationship. Here we are saying Frank-Starling law, because this was first time, this phenomena, okay, was first time discovered by Frank and Starling on frog heart. That's why the Frank-Starling law is mainly applied for the heart muscle. Okay, but the phenomena or the principle is similar to that of the cardiac muscle, that if you stretch the sarcomere more and more up to a certain physiological limit, it will go for more and more contraction. So what is the reason? If I ask you what is the reason of this Frank-Starling law, what is the cause of this increased contraction? I told you that this is due to increased number of cross bridge formation at the level of sarcomere. Increased number of cross bridge formation at the level of sarcomere. So how the ventricle is contracting more forcefully if you stretch? If you look at the molecular level, actin myosin cross bridge numbers will rise up to a certain physiological limit. This explanation for Frank-Starling law was there for decades. Now there is a recent explanation that apart from this number of cross bridge, the second reason for Frank-Starling law is that increased sensitivity of troponin C for calcium. Getting my point? So we all know that troponin C is going to bind with calcium and then the contraction will start. So even if the calcium is low, troponin has higher sensitivity towards calcium. So what does that mean? That means more stronger contraction is going to happen. What is the reason of this increased sensitivity? It is not known. But remember that the second explanation of this Frank-Starling law is increased sensitivity of troponin C for calcium. So this is about your Frank-Starling law, and we have just seen that more the end diastolic volume, more will be the force of contraction, and force of contraction is nothing but contractility of the heart. So in this diagram, in this flow chart, I can connect here that if your preload is more, it will directly increases the stroke volume. That is the direct effect. More the preload, more is the stroke volume. But indirectly, the preload can also increase the contractility of the heart, and this is by Frank-Starling law. Am I clear? So this is about Frank-Starling law and preload. Now second factor, we are coming here, the contractility. So all of us know that contractility mainly depends on these two systems, that is the sympathetic system as well as the parasympathetic system. Sympathetic system increases the contractility, parasympathetic system decreases the contractility. But apart from that, there are other factors that you have to remember. Okay, so I'm coming here. Contractility. Okay, it is increased by sympathetic system. We know the molecular mechanism how the sympathetic system increases contractility. We have discussed earlier. Then second thing, various drugs like digoxin. Okay, they also increases contractility. And another phenomena you have to remember specially here, that is known as Bowditch, Bowditch effect or Bowditch phenomena. All of this can increases the contractility of the myocardium. What is Bowditch phenomena? I am coming there. But before that, contractility will be reduced or decreased by, already I told you, that parasympathetic system. Okay, apart from that, if there is hypoxia, okay, this is causes direct depression of the myocardium. Okay, if there is myocardial infarction, right, if there is hypercapnia, okay, or if there is acidosis, all of them can directly depress the myocardium and your contractility of the myocardium will also be reduced. So these are the certain factors which has been given in Genong, so you have to remember them. But specially you have to remember here is the Bowditch effect. So what is Bowditch effect? This effect is also known as force frequency relationship of myocardium. Force frequency relationship of myocardium. What is the meaning of that? If you increase the frequency of contraction of the myocardium, your force of contraction will be increased. Simply, if I say, if you increase the heart rate of the person, the force of contractility or force of contraction is going to be increased. This relationship is known as Bowditch phenomena or Bowditch effect. Getting my point? If you increase the heart rate, suppose your heart rate is 90 and you increase the heart rate to 140. So your cardiac output will be high because cardiac output is equal to stroke volume multiplied by heart rate. But apart from that, increase in heart rate is also increasing the force of contraction of the myocardium, and that effect is known as the Bowditch phenomena. Right? So previously we have discussed more stretch is more contraction, that is Frank-Starling law. Now we are discussing more heart rate means more force of contraction, that is Bowditch phenomena. Now if I ask you what is the cause of this increased force frequency relationship or what is the cause of this Bowditch phenomena, then you have to remember the molecular mechanism of contraction, the molecular release of calcium during myocardial contraction. So suppose this is a myocardium cell. I told you in the previous discussion that whenever there is an action potential on this myocardium cell, the calcium will enter into the cell during phase 2 and that calcium will initiate the contraction. Okay, and this calcium is also going to release further calcium and that calcium will be released from sarcoplasmic reticulum. This discussion we have done in detail. But after the contraction is over, this calcium has to go out of the cell with the help of a transporter protein which is known as sodium calcium exchanger. Okay, sodium calcium exchanger is always coupled with sodium potassium ATPase pump. Okay, sodium potassium ATPase pump, because this sodium calcium exchanger is a secondary active transporter and sodium potassium ATPase pump is a primary. All of you know that secondary active transporter is dependent on primary active transporter. So that way this calcium is going out of the cell with the help of this sodium calcium exchanger which is linked to sodium potassium ATPase pump. Okay, so this is a normal thing. Now if I increase the heart rate, okay, what is going to happen? I can understand that again and again the action potential will reach on the myocardium cell. So more and more calcium is going to enter inside the myocardium cell. So again you have to throw this calcium by help of NCX. But you know that this sodium potassium ATPase pump, it is a slower acting pump. It requires some time for recovery. So whenever your heart rate is rising to a very high level, sodium potassium ATPase pump cannot keep pace with increased heart rate, and that's why whenever the sodium potassium ATPase pump is not keeping pace with the higher heart rate, there will be accumulation of more and more calcium intracellularly, and that will increases the force of contraction. Getting my point? So I can simply understand that if you increase the heart rate, more and more calcium will enter in the cell because again and again action potential is coming into the heart muscles, but the sodium potassium ATPase pump is lagging behind, because of which the NCX is also lagging behind, and that's why huge amount of calcium will be accumulated in the cell and that will causes increased force of contraction. This is known as Bowditch phenomenon. Right? So this is all about your contractility or force of contraction. Okay, so we are coming here to the original diagram. Right, so this is my original diagram. So now we came to know that contractility is regulated by various factors, and what are those factors we have discussed: sympathetic system, digoxin, Bowditch phenomena, and here we have discussed parasympathetic system, acidosis, hypoxia, hypercapnia. They are all decreasing the force of contraction. Now the last parameter which is written here is the afterload. Now let's discuss. But before that, I hope all of you remember that afterload is negatively related with stroke volume, means more the afterload, lesser will be the stroke volume. So what is afterload? Again, you have to think like this, that if preload means before, then what is the meaning of afterload? So I am writing here afterload, right? So same thing, after means after the onset of contraction. So after onset of contraction, the load means the tension which is applied on ventricular muscles. Ventricular muscles is known as afterload. So after the onset of contraction, the load or tension which is developed at the ventricular muscle, that is known as afterload. So now my question is, why the ventricular muscle will get tension during this afterload period? So this is after the onset of contraction. After the onset of contraction means you are measuring the load during systole or diastole. Obviously, this is the systolic load. So first of all, you remember this, that afterload means you are measuring the systolic load. So whenever the ventricle is contracting during systole, the first target of the ventricle is to open up this semilunar valve. To open up this semilunar valve, I told you that the ventricular pressure should be greater than that of the aortic pressure, or if it is right ventricle, ventricular pressure should be greater than pulmonary artery pressure. So I can understand that if the aortic pressure is high, then ventricle has to generate more pressure. If the ventricle is generating more pressure, obviously the tension which will be developed on this ventricular muscle will be more. That means I can understand that whenever the ventricle has started its contraction, the load or tension which is developed on this ventricular muscle is directly proportionate to the aortic pressure or aortic tension or aortic load. Getting my point? That's why it is said that afterload, the best index of afterload. So again the same question, the best index of afterload, okay, afterload is equal to aortic pressure. Aortic pressure, right? If I ask you which aortic pressure you are talking about, sir, mean aortic pressure. Getting my point? So please remember, previously I have discussed best index of preload is the end diastolic volume. Now the best index of afterload is the mean aortic pressure, MAP. But if you remember, we have already written that MAP, that if you multiply this cardiac output with TPR, you are going to get the MAP. That means MAP is determined by two factors. One is the cardiac output, which is almost fixed for a normal person, and it is the TPR which is going to change continuously from bit to bit, right? So MAP is mainly determined by TPR. That's why if the second question is asked that what is the best determinant of afterload, then your answer will be TPR, that is the total peripheral resistance. TPR you will understand in the next chapter in a very good manner, right? So TPR will be discussed in the next chapter. So best determinant of afterload is TPR, best index of afterload is the mean aortic pressure. Afterload means it is the systolic tension generated in the ventricular muscle. So now I can easily understand that if the afterload is high in a condition, suppose this person is suffering from aortic stenosis. Obviously, the ventricle has to pump very forcefully, and then only the ventricle will be able to eject blood, and that may be also lower than normal. That ejected volume will also lower than normal. So obvious thing, what will happen to the afterload? It will be more than higher. So aortic stenosis means afterload is high. Not only that, suppose the person is suffering from hypertension. So hypertension means aortic pressure is high. So ventricle has to generate more pressure or less pressure? More pressure. So again the afterload is high. So in case of aortic stenosis, in case of hypertension, in these cases I can say that afterload is very high. Afterload is very high. So whenever the aortic stenosis is developing, what will happen to stroke volume? Decrease. Whenever the hypertension is developed, what will happen to stroke volume? Decrease. That's why we earlier said that after load high means stroke volume is going to reduce. It is inversely proportionate. That's why if you look back in the previous diagram here, right? So here we are finding out that after load is negatively related with stroke volume. More the after load, lesser with the stroke volume. Increase after load will be seen in which condition? Like for example, aortic stenosis, hypertension, they are increased after load condition. Now, whenever your after load is high, ventricle can also increase its contractility. What I am saying? Now, there is a very peculiar phenomenon. Whenever your after load is rising, after load is increased, the ventricle will start contraction more forcefully. Increase contraction of ventricle. This relationship between after load and increased force of contraction is known as Anrep effect. This is known as Anrep effect. Right? So Anrep effect is nothing but increase after load is rising ventricular force of contraction or increased contractility. How this is going to happen? Right? So if you look at the mechanism of this Anrep effect, right? So increase after load. Suppose suddenly there is an increase after load in a ventricle. Okay. What will happen to the stroke volume? We have just discussed the stroke volume is going to decrease. Now, whenever the stroke volume is decreased than normal, what will happen to the end diastolic volume in the next cycle? What will happen? Tell me. So, whenever you are decreasing the stroke volume of one contraction, so more volume of blood will remain in the ventricle, and in the next contraction, it will get more and more blood. Okay, so it is getting blood from the atrium plus some blood is remaining. So, your end diastolic volume will increase. If your end diastolic volume is increased, what will happen to the myocardium fiber length? There will be increased myocardium fiber length. If there is increased myocardium fiber length, the Frank-Starling law will be applied, and that will lead to increased force of contraction. Getting my point? So this is the reason given for Anrep effect, that whenever there is increase in after load acutely, there will be increased force of contraction of the ventricle, and that is due to increase in end diastolic volume, right? But it is seen that there is another cause of this Anrep effect, because this acute effect will persist for few minutes. After that, the ventricle will be adjusted itself. But it is seen that even after few minutes, even after 15 to 20 minutes also, this Anrep effect is persisting. So what is the cause of this persistent increase in force of contraction in response to increase after load? It is said that after 15 minutes, okay, there will be increased release of calcium, from sarcoplasmic reticulum if your after load is high. Now, what is the reason of this increased release of calcium from sarcoplasmic reticulum? It is still not known, but it is said that chronically, or the later effect of Anrep effect is that increased release of calcium from sarcoplasmic reticulum, and acutely it increases the end diastolic volume, and by Frank-Starling law, force of contraction increases, right? So this is all about your regulation of cardiac output by multiple factor. We are not going to discuss the baroreceptor reflex and Benwich reflex here. It will be discussed along with the blood pressure regulation. But if I summarize all these things, three main effects you have to remember. That is increase in end diastolic volume, that is increase in length of the myocardium, is rising the force of contraction, increasing the force of contraction. Which effect? This is my Frank-Starling law or Frank-Starling effect, right? Then second thing, increase heart rate is rising the increased force of contraction. Which effect? This is nothing but BOWDITCH, Bowditch effect. And increase after load is also rising the force of contraction, and this is nothing but an rep effect. This is nothing but an rep effect. Getting my point? So these three things you should not forget at any point, right? Very, very important for your MCQ. Okay. Now, after discussing this whole cardiac output regulation, in some of the book, you may find out two terms, that is heterometric regulation of cardiac output, heterometric regulation of cardiac output, and homometric regulation of cardiac output. Regulation of cardiac output. Just remember, heterometric means you are changing the length of the myocardium, and that's why your cardiac output is changing. Simply, if you change the end diastolic volume, your myocardium length will change. So by changing this end diastolic volume, or by changing the preload, if you are changing the cardiac output, then this is known as heterometric regulation of cardiac output, or homometric regulation of cardiac output. The other two methods, that increasing or decreasing the afterload, is changing cardiac output. This is homometric regulation, as well as increasing or decreasing contractility, force of contraction, okay, by sympathetic or parasympathetic system. This is also under the homometric regulation, because here if you are changing the force of contraction of the myocardium by sympathetic system, you are not changing the length of myocardium, you are only changing the calcium content of the myocardium. If you are changing the afterload, you are changing the aortic pressure, ventricular muscle length, okay, is not going to change before the onset of contraction. So this is known as homometric regulation of cardiac output. And heterometric means whenever the EDV is more, the length of myocardium will be more, and that is known as heterometric regulation, right? Now, after discussion of this regulation of cardiac output, okay, we are going to discuss the Frank-Starling law a little bit more. What about Frank-Starling law more? Okay, so we have discussed that the Frank-Starling law, okay, what this law is saying, it is saying that more the end diastolic volume, more will be the increase in stroke volume, right? So if I represent this Frank-Starling law with the help of a graphical representation, look at here. X-axis is the end diastolic volume, and y-axis I am plotting the stroke volume, right? So in this relationship, the Frank-Starling law or Frank-Starling curve is plotted like this. Okay, so this red color curve indicating that more the end diastolic volume, more will be the force of contractility, more will be the force of contraction, and more will be the stroke volume. And this will ultimately, this law will follow up to a certain physiological limit. After this physiological limit, okay, no further increment of stroke volume is possible. Why so? Because I told you earlier that Frank-Starling law, the mechanism is increased number of cross bridge formation. But if you go on stretching and stretching the myocardium, ultimately there will be rupture of sarcomere at the molecular level, and that rupture is this physiological limit, right? So very simple thing is that more the end diastolic volume, more will be the stroke volume by the ventricle by Frank-Starling law. So if I draw a curve like this, which is located below this normal curve, okay, so suppose this red color curve is a normal curve, so I can easily understand that this indicate any factor which is decreasing the force of contraction of the myocardium. So decrease contractility of the myocardium will produce this kind of curve, which is located below the normal curve. And decreased contractility, we have already seen that parasympathetic system, okay, hypoxia, all these things are going to cause this kind of curve. And very simple is that if I plot a curve which is above this normal curve, so this indicating that this is increased contractility of the myocardium, of the heart. That's why increased contractility is caused by maybe sympathetic, maybe digoxin or Bowditch phenomena. All of this will have this kind of curve, right? Now, why we are discussing this graphical representation? Suppose I am saying a person is suffering from heart failure. So how this Frank-Starling curve will look like? Okay, please note down that there will be initial rise of stroke volume, but after that there will be a plateau. If you are getting this kind of curve like this curve is typical of heart failure curve. So this is a curve which is plotted from a heart failure patient, indicating that initially whenever there is increase in end diastolic volume, stroke volume is rising, but after that this plateau means more and more end diastolic volume is rising, but for that rise of end diastolic volume, cardiac output or stroke volume is not rising at all, and this is typical of heart failure patient, right? So if you give different treatment to this heart failure patient, how this curve will shift towards normal curve, that we are going to discuss next. So this is x-axis, okay, and this is y-axis. Again the same Frank-Starling curve. Now x-axis is end diastolic volume, but here I am plotting end diastolic pressure, okay, end diastolic volume or end diastolic pressure, and y-axis is stroke volume. Obviously stroke volume is also a determinant of cardiac output, okay. So I am drawing the normal curve here, okay, and this is the curve of heart failure patient curve, right? So suppose that this pressure is 15 millimeter of mercury and here the pressure is 25 millimeter of mercury. You have plotted this curve from which ventricle? This is plotted from left ventricle, okay. So what is the normal left ventricular end diastolic pressure? Normal end diastolic ventricular pressure is in and around 10 millimeter of mercury, okay, that is 4 to 12, but in and around 10 millimeter of mercury. So here in this curve we can find out that the end diastolic pressure is rising more than 15 millimeter of mercury. Again it is rising more than 25 millimeter of mercury, but still no rise of stroke volume, no rise of cardiac output. So what that indicate? That indicate that heart is not able to pump properly. So that will leads to increase of pressure at the level of left atrium, and that will leads to pulmonary congestion. So this way we know that whenever your end diastolic pressure is rising more and more and it is going above 15 millimeter of mercury, but proportionate stroke volume or cardiac output is not rising, then that is typical of heart failure patient. Now suppose I have given some treatment to this heart failure patient. So this is the point where the steady state condition is prevailing, okay. So heart failure steady state condition, that is point number A. After giving certain treatment, the point is shifting towards normal curve. So suppose it is shifting from A to B point, okay, A to point number B. You have to tell me which drug I have given. Then I have given another drug which is shifting this curve from A to point number C, and another drug, that is the drug number 3, that is shifting the curve from A to D, right? So this red color curve is the normal curve. So because of the treatment, the heart failure patient curve is shifting towards the normal curve, but all these three shifts are different. A to B shifting, A to B shifting, A to B shifting. So what is the meaning of A to B shifting? I can see here that whenever the shifting is occurring from A to B, only and only your stroke volume is rising without any change in end diastolic volume or end diastolic pressure. Means you are not changing the end diastolic volume or pressure, you are only rising the force of myocardial contraction, and because of which your stroke volume and cardiac output is rising. Could you guess the drug which is shifting A to B? Obviously, this will increase the force of contractility, and the drug is digoxin, right? So if you give digoxin, this heart failure patient curve will directly shifting towards the normal curve and without any change in volume. Then you look at A to D. Now I am asking A to D shifting. A to shift I will come later. A to D shifting. So I can understand here A to D shifting means in this shifting there is only decrease in end diastolic pressure, but force of contractility or the stroke volume is not rising at all. Only the volume is decreasing, only the end diastolic pressure is decreasing. So end diastolic pressure depends on end diastolic volume, and that depends on venous return. So by some means, if you reduce the volume which is returning to the ventricle, then this thing is going to happen. That means you have to cause a certain volume loss, and that is typically done by diuretics kind of drug. So if you give diuretics, your volume will change, but contractility is not going to change. Your stroke volume is not going to change. Now A to C shifting is very, very important. A to C shifting is very, very important, because here I can find out the shifting is occurring towards leftward side also, towards upward side also. Okay, so I have to find out one drug which is causing this A to C shifting, and the drug is nothing but ACE inhibitor. ACE inhibitor, right? Why ACE inhibitor is causing both shift? Means it is decreasing volume also, it is rising stroke volume or force of contractility also, right? So ACE inhibitor, all of you know that in a heart failure patient, when the heart patient is suffering from heart failure, his sympathetic system is overactive, and when the sympathetic system is overactive, it is a stimulus for huge amount of secretion of renin, and whenever renin is secreted more, it will stimulate the conversion of angiotensin 2. Okay, you know the pathway that renin will convert angiotensinogen 1, and that will be converted into angiotensinogen 2. So angiotensinogen 2 will be very, very high in heart failure patient. And angiotensin 2, it's a potent vasoconstrictor, mean it will causes constriction of the veins also, it will causes constriction of the arterioles also. So venoconstriction as well as arterial constriction, venoconstriction as well as arterioles constriction, both is going to happen due to this increased angiotensin 2. So whenever I am giving this ACE inhibitor drug, angiotensin 2 production will decrease. So what will happen in that cases? So ACE inhibitor, whenever I am giving, the angiotensin 2 level will be reduced. Whenever this is reduced, I can understand that there will be dilation of the vein, so venodilatation, right? As well as it will also causes arterioles dilation, right? So now if you causes venodilatation, so your veins are dilated, so I can understand there will be more pooling of blood inside the vein. So if more blood is stored at the level of vein because of venodilation, what will happen to the venous return to the heart? It will decrease. If your venous return is decreased, what will happen to the end diastolic volume? Okay, your end diastolic volume will decrease, your preload will decrease. So that's why the ACE inhibitor means it will reduce your end diastolic volume, and that's why the curve will shift towards the left side. So end diastolic volume decrease means end diastolic pressure will also decrease. Now if you look at the arteriole dilation, you know the arterioles are known as the resistance vessels. So if you causes dilatation of the resistance vessel in the body, then there will be decrease in total peripheral resistance of the body. Total peripheral resistance is a determinant of afterload, right? If your afterload is decreased, what will happen to stroke volume? Stroke volume is going to increase. That's why you can see that angiotensin converting enzyme inhibitor drug is reducing angiotensin 2 level. By reducing angiotensin 2, it is decreasing the preload of the ventricle as well as it is also decreasing the afterload of the ventricle. If you decrease the preload, your end diastolic pressure will be decreased. If you decrease the afterload, your stroke volume will be increased. And that's why we can see here that the curve is shifting not only in the upward direction, okay, that is due to increased contractility, it is also reducing the volume. That's why it is shifting in the leftward side, upward side. So combination of these two is nothing but a neutral position, that is from A to C shifting. So this A to C shifting is due to angiotensin converting enzyme inhibitor, right? So this is about your Frank-Starling curve and applied aspect. Okay, this kind of diagram can be given easily in image-based question, and you know this is combination of physio and pharmacology, so you are going to get this kind of question in your future, right? So now after discussing all of this regulation of cardiac output, we are now habituated with three terms, that is preload, afterload and contractility. Now with these three terms, we are going to discuss the cardiac cycle once again, but in a different manner. and that is known as PV loop of the cardiac cycle. PV loop. Okay, very common term, pressure volume loop. So pressure volume loop is nothing but discussion of the cardiac cycle phases, but x-axis will be volume and y-axis will be pressure. Previously we have discussed Uyghur's diagram. In Uyghur's diagram, recall, x-axis was the time axis and y-axis was the pressure axis. In PV loop, the x-axis we are going to plot the volume and y-axis we are going to plot the pressure, and it will form a loop, and that loop is known as PV loop or pressure volume loop of ventricle, right? So how this loop is plotted, right? Okay, so first I will draw the axis. Okay, x-axis and y-axis. So x-axis is the volume or end diastolic volume, or simple I will write down volume here, and y-axis is the pressure. So in this axis, first I am drawing one simple line. Look at this line, just a simple line I have made here. Okay, what is the meaning of this line? If I ask you what is the meaning of this line, this line indicating that whenever your volume in the ventricle is rising more and more, okay, the pressure in the ventricle is not rising to a very high level, very little rise of pressure. Getting my point? If the curve is rising like this, then high rise of pressure. Okay, so this line indicating that although the ventricular volume is rising to a very high level, but pressure rise is not very high, very little rise of pressure. That is the meaning of this line. So I am marking this. Suppose this is A to B. Okay, we are plotting the curve from ventricle, particularly the left ventricle. So I am writing here A to B. This indicate this is the filling phase of ventricle. This is filling phase of ventricle. If I ask you, could you recall the filling phase of ventricles? Okay, obviously the first rapid filling phase plus diastasis, okay, plus last rapid filling phase. During all this filling phase, the ventricle is in a relaxed condition. More and more blood is coming into the ventricle, but ventricle is stretching proportionally. So what will happen? The pressure rise in the ventricular muscle will not be very high, right? Not be very high. That's why you can find out that point number B is not a very high rise point. It's a very low level point. So this indicate this is the filling phase of cardiac cycle. Ventricular filling is going on. So at the end of ventricular filling, the total volume of blood which is present at point number B is nothing but my end diastolic volume. So I'm writing here that at point number B, end diastolic volume is present in the ventricle. Now, whenever the ventricle is filled with end diastolic volume, could you tell me which phase of cardiac cycle is going to start? Your simple answer, isovolumic contraction, sir. So what do you mean by isovolumic contraction? Isovolumic contraction. Isovolumic contraction means volume will remain same, but pressure in the ventricle will start rising more and more. So if I have to draw a curve like this, the curve will go like this. This curve indicating the pressure is rising to a very high level, but volume is remaining same, that is equal to the end diastolic volume. That will indicate the isovolumic contraction, right? But before that, look at what is the ultimate target of this isovolumic contraction. Ultimate target is to open up the semilunar valve. To open up the semilunar valve, you have to overcome the aortic pressure. Just now we have discussed aortic pressure is also known as afterload. So first I am marking this aortic pressure or afterload line in this plot. So this line indicating afterload line, right? Afterload line, that means this is the aortic pressure line. So now if I look at the isovolumic contraction phase, so ventricle is contracting more and more, the ventricle is contracting more and more without any change in volume, but the pressure is rising more and more. Now you look at this point number C. At point number C, the ventricular pressure is going above the aortic pressure. What is going to happen? The semilunar valve is going to open up. So at point number C, opening of semilunar valves or aortic valve, you can say. And I can say like this, that this B to C, this is nothing but isovolumic contraction phase of ventricle. Getting my point? So A to B is the filling phase of ventricle, B to C is the isovolumic contraction phase of ventricle, during which is ventricle is generating pressure more and more, but no change in volume. Then whenever this semilunar valve is open up, we know the ejection phase of ventricle will start. Ejection phase means, look at the curve, there will be increase in force also initially, and there is decrease in volume also. Blood is ejected from ventricle, so what will happen to the volume of blood? Decrease means the curve is going to shift to the left side. Along with that, initial phase of ejection, the ventricle will also rise its pressure. So initially the pressure is rising but volume is decreasing, but after some point of time the volume and pressure both are going to be decreased inside the ventricle like this. Now the curve has reached to a point, suppose this is point number D. Now at point number D, okay, I can understand that the ventricular pressure is going below the aortic pressure. Look at, ventricular pressure is going below the aortic pressure and the momentum of the blood is also gone. So what will happen? This will lead to closure of the aortic valve, otherwise the blood will backflow. So at point number D, I can write down like this, that this is the point where there will be closure of semilunar valves, right? So closure of semilunar valve is going to happen. This is your second heart sound point. So this C to B, this is nothing but your ejection phase of ventricle. I hope there is no confusion here. So during ejection, your volume is also changing, your pressure is also changing, both are changing. Okay, normally we have seen that isovolumic contraction means volume is same, the tone is changing, or you have seen the isotonic contraction, isometric contraction. In case of ejection of the ventricle, both changing, your volume is also changing, pressure is also changing. This kind of contraction where both are changing, this is known as auxotonic type of contraction, and this is nothing but your ejection phase of ventricle. So auxotonic contraction means when pressure and volume both are changing proportionally during a contraction, that is known as auxotonic type of contraction, that is ejection of ventricle. Now at point number D, the semilunar valve is closed. After the closure of the semilunar valve, which phase of cardiac cycle is going to start? Isovolumic relaxation. So isovolumic relaxation means I can easily understand that the volume will remain same, but the pressure in the ventricle will drop down to a very low level like this. So now it will reach at the previous point, that is point number A. So getting my point? So this, just hold on, I'm writing here A. So this D to A point, this is nothing but isovolumic relaxation point. So I'm writing here D to A. This is nothing but isovolumic relaxation phase of ventricle. So now you please note down that at the end of this isovolumic relaxation phase, okay, there is very minimum volume of blood still present in the ventricle. This volume of blood which is still present in the ventricle, this will be known as end systolic volume. Okay, and at point number D, at point number A, this is the end of isovolumic relaxation. At the end of isovolumic relaxation, the ventricular pressure is very low. So whenever your ventricular pressure is very low, okay, atrium pressure is high, what is going to happen? We all know that this is the point where there will be opening of mitral valves or atrioventricular valves. And whenever there is opening of mitral valves, there will be more and more filling of ventricle. So ventricular filling is going on. That's why I told you that this is the filling phase of ventricle. At the end of the filling, the total volume of blood which is present at point number B is known as end diastolic volume. Whenever the ventricle is getting end diastolic volume, it will start contraction, and immediately after the onset of contraction, what is going to happen? There will be closure of these mitral valves or atrioventricular valves. Getting my point? And whenever the mitral or atrioventricular valve is closed, then and then only the isovolumic contraction phase is beginning, and then this ejection phase will start, and now the loop will continue like this. So now you are saying that whenever we are plotting the cardiac cycle with respect to volume and pressure, it is forming a loop. And this loop is known as pressure volume loop of cardiac cycle. Getting my point? So this is simple, nothing but discussion of the cardiac cycle only, but in a different manner. So obvious question is that if I ask you where the second heart sound is going to happen, this is the point where the second heart sound will appear, and this point number B, this is the point where first heart sound is going to appear. So these are the very two important point. And if I ask you third and fourth heart sound, we all know that third and fourth heart sound occurs during the filling of ventricle, first rapid filling phase, last rapid filling phase. So somewhere here there will be third heart sound, and somewhere here there will be fourth heart sound. So this is about the normal PV loop of left ventricle, right? Now after understanding this normal PV loop, if we go some abnormalities of this PV loop, right? So we have to understand three things. That suppose due to certain problem, due to certain pathology, the end diastolic volume of a person is high. So EDV is high. What will happen to this PV loop? Okay, so I'll draw a normal curve first. Suppose this is the normal curve. So normal curve will look like this. Okay. So this is the normal curve. Okay. If there is increase in end diastolic volume, simple I can understand that this point will be shifted on the right side. More and more EDV means more and more shifting of this point number B towards right side. Then suppose this is the new B dash is the new end diastolic volume point. So the ventricle will start its isovolumic contraction from here. Okay, so it is contracting, assuming that the aortic pressure is not changed. The ventricle will start its ejection from this point, and the curve will look like this, right? So this kind of curve is known as right shifting of PV loop. This is known as right shift of PV loop. So bottom line is that increase in diastolic volume means this will causes right shift. Getting my point? Okay. The next thing is that second parameter, increase in contractility of the heart. Increase in contraction of the heart. Contractility or contraction of the heart. What is going to happen? Again the same thing. Suppose this is the normal PV loop. Normal PV loop, write this. Okay. In this normal PV loop, if the contractility is more, okay, so volume is not changing, so everything, this point number B will remain same, ejection will also start from the same point, but after ejection, because the ventricular contractile force is very high, the contraction will persist for some long time, and the curve will look like this. Because the force of contraction is high, the ventricle is pumping more forcefully for longer duration. Okay, more ejection, right? So what is happening here? I can find out that this A point is shifting on the left hand side. A point, the blood which is present at the A point, that is nothing but end systolic volume. So end diastolic volume is remaining same, end systolic volume is decreasing. What will happen to the stroke volume? Obvious thing is that stroke volume will increase, because we know stroke volume is nothing but the difference between this A and B point. So if your end systolic volume is decreased, remaining your end diastolic volume same, your stroke volume is going to be increased, and we all know that increased contractility, increased force of contraction means stroke volume increases. So this is also explained by the same kind of curve. This kind of shifting is known as leftward shifting of the curve. So please remember, left shifting, okay, is occurring due to increased force of contraction. So increase end diastolic volume, right shifting, increase contractility, left shifting. Now look at increase in afterload, increase in afterload, right? So increase preload, increase contractility we have seen, now increase afterload. This is normal curve, okay, normal curve, right? So in this normal curve, I told you that ejection will start from this point, and this is nothing but after load line. Whenever the ventricular pressure is more than aortic pressure, ejection will start from that point. If your after load is high, simple thing is that this line will be shifted in the upward direction. So this is high after load. Okay. So now your after load is high. During isovolumic contraction, ventricle will start contracting like this, but he will not be able to eject blood from this point. He has to generate some more pressure, and then only it will be able to overcome the aortic pressure. So the ejection will start from here, but the ejection will not continue for longer duration because the aortic pressure is high. So semilunar valve will be closed earlier and the curve will look like this. So getting my point? Okay, your remaining blood in the ventricle, that is the end systolic volume, is rising. End diastolic volume is remaining same. So what will happen to stroke volume? Stroke volume will be decreased. That we have discussed earlier, that increase after load means stroke volume will decrease. But the main shifting that is happening here is this kind of shifting, as if the curve is shifting in upward direction. That's why we say after load means upward shifting of PV loop. Getting my point? So three bottom line I have to remember to discuss the abnormality. Increase preload means the rightward shifting of the curve. Increase contractility means leftward shifting of the curve. Increase afterload means upward shifting of this curve. With this concept, if I go back to our discussion here, okay, right here. So now we have to discuss the valvular pathology and cardiomyopathy pathology with this concept. So this is a valvular disease, right? We have also discussed this stenosis and regurgitation in the previous discussion also. Here also we are going to discuss. So aortic regurgitation, mitral regurgitations. If you think of both of this condition, aortic regurgitation, okay, I told you in the previous class that aortic regurgitation means during this diastole, okay, semilunar valve should be completely closed, but that is not closed properly, that is regurgitation. So what will happen? Some blood will return from aorta to the ventricle, and this ventricle is also getting blood from right atrium. So it is getting blood from aorta also, it is getting blood from right atrium also. What will happen to the end diastolic volume? End diastolic volume will increase. End diastolic volume increase means which shift? Right shift. That's why you see here this red color curve, this is nothing but right shifting. So I'm writing here aortic regurgitation means there will be right shifting of curve, right? Okay. In case of mitral regurgitation, the similar kind of phenomena but in a different chamber. So this is arch of aorta, this is left ventricle, and this is my left atrium. This is left atrium, right? Mitral regurgitation means during systole, when the ventricle is contracting, the blood is regurgitated back in the left atrium. The blood should go here in the arch of aorta, but it is going back to the left atrium. So left atrium will be enlarged, left atrium pressure will be enlarged. Why? Because left atrium is also getting blood from pulmonary vein. That is a normal flow of blood from pulmonary vein to left atrium. So what will happen? The left atrium getting huge amount of venous return. If your venous return is rising, what will happen in the next cardiac cycle? This will drain huge amount of blood in the ventricle. So what will happen to the end diastolic volume in the next cardiac cycle? It will be rise, it will be higher, and that's why again in case of mitral regurgitation I can see that there will be right shifting of this curve. So again there is right shifting of the curve here, right? But if you look at these two curves closely, you are finding out that in case of aortic regurgitation, not only right, there is also a little upward shifting of the curve. Okay, right is going on, Okay, but still little upward shifting of this curve. But here in case of mitral regurgitation, upward shifting is not there. This upward shifting is not there. So I can remember like this, aortic regurgitation means right shifting plus upward shifting is also happening. So right and up shift. Okay, please note down. Now why there is upward shifting in aortic regurgitation but not in mitral regurgitation? Curve shifting upward means what is increased? Afterload is increased. Afterload means aortic pressure is increased. Now could you explain that in case of this aortic regurgitation, aortic pressure will increase? Why? Because whenever the ventricle is getting more blood during end diastolic volume, then think of the next cardiac cycle, what will happen during systole. He has received huge amount of blood. Now this blood is going to be ejected in the arch of aorta. So what will happen to the stroke volume in case of aortic regurgitation? Stroke volume will be higher. If the stroke volume is high, what will happen to the systolic blood pressure? Systolic blood pressure will be high. If the systolic blood pressure is high, that means your afterload is also higher. That's why not only the right shifting, there will be a little upward shifting in case of aortic regurgitation, that is due to increase in aortic pressure. You may think that why this is not happening in case of mitral regurgitation. Look at, whenever the ventricle is contracting in case of mitral regurgitation, more of the blood is returning back to the left atrium rather than arch of aorta. Most of the blood is returning here rather than arch of aorta. That's why in case of this mitral regurgitation, the aortic pressure will not increase to a very high level. That is the reason there is no upward shifting of the curve in case of this mitral regurgitation. Now look at the stenosis. Very easy. If there is aortic stenosis, we have given this example earlier. Aortic stenosis means increase in afterload. So what kind of shift is going to happen? Upward shifting of the curve is going to happen. So the curve is shifting in upward direction. But I told you that if the aortic stenosis is acute, then it will shifted in the upward direction. But in case of chronic aortic stenosis, you know that there will be ventricular hypertrophy, compensated hypertrophy, as well as ventricle will also increase its force of contraction by ANREF effect. We have discussed. So what I am saying, that if there is aortic stenosis, ventricle will try to pump more forcefully, chronically, the muscle will get hypertrophied. So whenever the muscle is getting hypertrophied, what will happen to force of contraction? Force of contraction increases. What is the effect of ANREF effect? Increased force of contraction means contractility is high. If the contractility is high, the curve will shift in which direction? Leftward direction. That's why in case of chronic aortic stenosis, the curve will not only shift in the upward direction, but there will be shift in the leftward direction also. So that's why up and left shifting will occur in case of chronic aortic stenosis. In case of acute aortic stenosis, only upward shifting is going to happen. This chronic aortic stenosis was given in AIIMS entrance examination, but in the option up and left was not there. In the option it was there counterclockwise movement of PV loop. So it is moving in opposite to the clock direction, counterclockwise movement of the PV loop, that is in aortic stenosis. Now in case of mitral stenosis, you know that because of the stenosis of the mitral valve, so I can imagine like this, that if this is the arch of aorta, this is ventricle, and this mitral valve is stenosed here. Because of the stenosis of this mitral valve, what will happen? The blood will not be able to reach the ventricle. So what will happen to the ventricular end diastolic volume? It will be very less. But the force of contraction of the myocardium is same. So although it is getting less blood, it will try to eject as much as possible blood from this lower amount of end diastolic volume. So what I am saying, suppose normally end diastolic volume is 130. Now the ventricle is getting 100, but within this 100 it is going to eject 70 ml because force of contraction is not changed. So previously you are ejecting 70 ml from this 130 ml. Remaining blood in the ventricle was more. Now from this 100 you are ejecting same 70 ml. So what will happen to the remaining blood in the ventricle? Lesser. That means I can understand that in case of mitral stenosis, end systolic volume will decrease as well as the end diastolic volume will also decrease, but more decrease will occur in case of end diastolic volume. So if your end diastolic volume is decreasing, you can easily find out here, this is the decrease end diastolic volume, means the curve has shifted in this direction, okay, and this end systolic volume is also reduced, okay. So obviously again here also the curve is shifted on the left hand direction. That's why we say mitral stenosis means left shifting of PV loop. Getting my point? Although the contractility is not high, but still there is left shifting because of decrease in end diastolic volume. Right? So you have to remember. Okay. So aortic regurgitation right and up, mitral regurgitation right, aortic stenosis up or up and left in chronic cases, and mitral stenosis means left shifting. Now the last to this discussion is cardiomyopathies, right? So all of you know the cardiomyopathies means it is some acquired or inherited conditions which is primarily affecting the muscles of the heart. Okay, this is not due to secondary causes. Primarily the disease is affecting the myocardium. And you know that there are three different types of myopathies are there. Dilated myopathies, where the left and or right ventricle will be hugely enlarged, hugely dilated with impaired systolic function, right? So heart is not able to pump, plus it is getting huge amount of dilated, huge amount of end diastolic volume, right? So if you look at dilated cardiomyopathy, the major problem is end diastolic volume is very high, and end systolic volume is also high because the contractility is less, ventricle is not able to pump properly. Getting my point, right? But if you look at the hypertrophic cardiomyopathies, the muscle is getting hypertrophy, particularly the septal region will be get hypertrophied. So there will be left ventricular hypertrophy, typically involving the septum. But again, you look at what is the problem? Your end diastolic volume will decrease because of the hypertrophy, which is reducing the chamber volume. So decrease in end diastolic volume, right? End systolic volume will also decrease, right? And what will happen to contractility? Obviously, because of this hypertrophy, the contractility will increase. But because of chamber cavity is reduced, the end diastolic volume will reduce to a very severe level. Now, the third one is the restrictive cardiomyopathy. The myocardium will not able to stretch during diastole. That is restriction of dilatation, restriction of stretching of the myocardium. Why that is going to happen? If there is certain kind of scar in the myocardium tissue or certain kind of infiltration in the myocardium tissue, so fibrous tissue is going on in the muscles of the heart, so muscle is not able to stretch during diastole. So what will happen? Whenever the blood is reaching during diastole, end diastolic volume is reaching, the ventricle is not able to stretch. What will happen to the end diastolic pressure? It will rise to a very high level. So look at here. In case of restrictive cardiomyopathy, the end diastolic volume, end systolic volume may be normal or may be decreased. Okay, and contractility may be also normal or decreased depending on the different disease state, right? But if you look at the PV loop, there is some difference between this restrictive and hypertrophic cardiomyopathy. Dilated cardiomyopathy is very easy to understand because end diastolic volume is severely huge, right? So look at this three curve. First, you look at this dilated cardiomyopathy. What you're looking at? The curve is completely shifted from the normal curve. Okay, outcast, right? So it is located away from the normal curve where the end diastolic volume is very high than normal. End systolic volume is also very higher than normal. Okay, so first you look at the normal curve. Okay, this is your normal curve, right? You can find out here, this is the normal curve. Okay, so it is very away from normal curve, and which kind of shift this is typical of right shift. So I have to remember, dilated cardiomyopathy means there is right shift, hugely right shifted. Now, restrictive cardiomyopathy. I told you restrictive means the myocardial is fibrous, myocardium scarring is there. So what will happen? The end diastolic pressure line will be very higher position. Getting my point? Normally I told you this end diastolic volume line or this filling line, the pressure is not very high, but during the filling of ventricle, if the end diastolic pressure is high, so what will happen? This curve, this filling curve will be shifted in the upward direction. This filling curve is shifting in the upward direction. So you look at here, because this filling curve is shifting upward, the whole curve, the whole PV loop has shifted in the upward direction like this. That's why we say that restrictive cardiomyopathy means there is upward shifting of the curve, but this upward shifting is not due to increase in afterload. Okay, don't confuse. This upward shifting is not due to afterload increments. This upward shifting is due to increase or due to upward shifting of the base of the PV loop. Base of the PV loop means that is the filling phase of ventricle. Okay, during filling, the ventricle is not able to stretch properly, so huge amount of pressure is increased in the ventricle. That is the upward shift. And hypertrophic cardiomyopathy means we know that there will be increase in force of contraction, increased contractility. So if your increased contractility is there, we have seen earlier, that will shift the curve towards the left hand side. So that's why hypertrophic cardiomyopathy means the leftward shifting of PV loop. Although there is little upward shifting also, but main shifting is the leftward shifting. So this is the curve of hypertrophic cardiomyopathy. Not only that, if you look at the hypertrophic cardiomyopathy curve, the curve is also very, very narrow. Okay, because I told you that there is no space for accommodating end diastolic volume. That's why the curve is looking narrow, right? So these are the three different cardiomyopathy. I have to remember that this dilated cardiomyopathy means there will be right shifting, hypertrophic cardiomyopathy means there will be left shifting, restrictive cardiomyopathy means there will be upward shifting of the PV loop. So this is all about your cardiac output and its regulation.